I am a psychiatrist and public department, and I'm a senior Atlantic fellow for equity and brain health with Trinity College. So I'll carry on with the moderation. Next we have clinical care and delivery. Who is presenting? It's supposed to be cool. Okay, lifting as we rise.
What's going on here? Good morning, everyone.
Oh, even with my heels, I'm so short. Good morning, everyone. Okay, I don't know what's happening. Should I just manualize it? Is it on?
Yeah.
Okay. Hi. Okay, so down is up. Did I get it wrong as well?
The middle one.
Middle one. Yes, okay. So, my name is Lishem Gweba Biwana. I'm somewhere there, third one. And I'll be giving feedback on the clinical care delivery group. And I think from the onset, when we're reflecting back with my co-presenter, who's sitting there, Dr. Anisha, we're seeing even the profile of representation there is quite South Africa heavy, so that's already sort of our departure point that we hope we can get more representation from everyone across the continent and it not turn into a primary South Africa subgroup or working group. So we had sort of a diverse range of areas of interest within that working group. There's quite a strong cohort of people interested in addictions. So there's the sleep whisperer out. Okay, so she was also in our working group. And then also adolescents and geriatrics came out as well, and then child and adolescent psychiatry. And the other broad area of interest was collaboration and co-creation with other people within the mental health space who may not have formal training in psychiatry, such as informal mental health services, NGOs, and other organizations that we could potentially collaborate with. And I think just in terms of the areas of interest, there was this sense of, looking across the spectrum from, the babies, neonates, adolescents, adult psychiatry, and all the way to geriatric psychiatry, so that sort of longitudinal view across the lifespan. We then talked about potential platforms of engagement, and the tech space took quite a lot of time off our discussions because we thought, there's one way of trying to level the playing field and overcoming some of the disparities that we know exist in terms of clinical care delivery across the continent. And we discussed platforms such as EMG, which is, Anisha touched on a lot yesterday around the app that is being used across different countries within Africa, and how we could potentially collaborate with them and setting up little clips and insight and information that could be then uploaded there, and we just had a discussion around how sort of the shape or form that could take. We also talked about YouTube videos and how we could upload those in the segments, again, because the big theme around, that people's attention span is quite short, so having lengthy discussions that are going to be laborious is not going to be practical for, clinicians in resource-constrained settings who already don't have time. So, short snippets at the most, like 20 minutes, but even shorter, like 5-10 minute videos or clips, visual aids to assist. And then I think also the media, which also links to the other work groups, that we need to be leveraging media and those platforms more, especially if you're in a very resource-constrained setting, data, access to Wi-Fi could be one of the barriers to accessing even these, videos that we're talking about on YouTube. You need data to access that, and video takes a lot of, data, so, we may not be able to get that across to everyone, but if we're collaborating with the local media, inserts on local radio stations, and just more presence within that space with the platforms that people engage with and are likely to listen to. If we can get that going, that's another way we can get our message across. And then the other broad area of potential platform of engagement is around outreach. So there was a discussion around, if there's a country that doesn't have a child psychiatrist or a neuropsychiatrist, could we have platforms for, or even a psychiatrist, even beyond just general psych, specialized subspecialties as well. Grand rounds, if people are willing, to, and depending on capacity, maybe monthly or 3 monthly opportunities where clinicians in those settings could then have access, maybe an hour on Zoom with someone with a particular interest or expertise in that area, and then they can bring the most challenging cases and present them, and a general approach to managing someone with that condition could be discussed. And then the question came out, then who would provide this? Because I know we're speaking to a room of very busy clinicians, researchers, so again, feasibility and sustainability of that, and the issue of importance of commitment. So if someone's committing to have 4 grand ward rounds in 2023 with a particular institution, that then the importance of keeping that commitment unless something catastrophic has come up with it, but they're just sustaining that, then having this grand plan that then falls apart, and kind of perpetuating this, the inequity that's already in existence. So how often, who will, and then who's going to commit. And then the last aspect around the potential platforms was around observations of clinical practice, because sort of the last line recaptures it, that's we all know what to ask, but we may be more around not knowing how to ask it. So maybe having a simulated interview where you're seeing psychiatrists taking developmental history or whatever aspect of the history that how you get the information out from an adolescent, from a cognitively impaired geriatric patient, and sort of other aspects that although you may have the Clarkin sheet or the Maudsley Clarkin sheet or whatever Clarkin sheet you're using, but how do you then get the information from the patient in a way that is going to give you what you need to make a proper assessment. And so we discussed simulated interviews and sort of even maybe showing how to do motivational interviewing. So we have all these tools. We talk about CBT, we talk about brief interventions, but it may be around having simulated little video clips of then this is how you actually do motivational interviewing with the patient. And then we went sort of a bit more deeper to talk about the potential topics then that we want to cover, because there's a lot that we can cover obviously in this space, but we thought broadly, given our interest and given what we foresee as the need, we thought dementia was a big topic that we would want to touch on, around awareness, screening, the care of the family who has to look after someone living with dementia. And it came out strongly the importance of considering the cultural and social factors, because we can tell someone that, if your relative is very severely impaired, they may need to go to a care facility, and how that discussion takes form in our cultural context where the older relatives are often cared for by the family, and how placement can be frowned upon, and how we navigate those discussions around care, what is dementia, and at which point do we have the discussion, and how to have that discussion with relatives around possible alternative care platforms or modalities. The other big potential topic was around mental wellness. So again, we were talking not just at the end when things have completely gone awry and someone now has already got the disorder, but focusing on wellness and sleep again featuring prominently, talking about what is normal sleep and, and mood disorders, emotions, and what is normal, because then once everyone's on the same page about what is normal, then we can go on to talk about then when things go wrong and when the pathology starts. There was also a big discussion around the adolescent brain and how often misunderstood it is, and we thought then that this could link into sort of sub-discussions around the adolescent brain in the context of addictions. The neuroscience of the adolescent brain, adherence, and all the other aspects that we've listed there. Okay. Another big subsection was around neuropsychiatry, thinking around sort of the big topics in the African context, traumatic brain injury, HIV, epilepsy, and then I just mentioned to the team that there are already notes in neuropsychiatry that are freely available at the UCT website that Prof. Joska has put together with a few neuropsychiatrists in the Western Cape. And those are freely accessible now. If you go there, you can access them. And it's just like little notes, practical for around how to approach the core neuropsychiatric topics for registrars or even people with an interest in neuropsychiatry. And the last section we talked about was around repurposing of medication. So that's where the discussion started, and then it kind of meandered off into related aspects. So the concept of off-label use and sort of using medications for other purposes than what the pharmaceutical company may originally have said, which we do in commonly in practice, but then sort of making that more formalized or sort of the next big thing was the concept that came out a lot in the discussion. Like, okay, this is what the international guidelines are saying, but if I'm out there in a resource-constrained setting, then what is the next best thing to do? And then off-label use came up in that context, and the use of older agents. That, again, if you have in a more resource-constrained setting, you may have access to those than, the newer atypical antipsychotics, for example. And then that if you have no access to any medication, then, that's how we got to the non-medical, non-pharmacological alternatives, again, concepts around, CBT for insomnia, mindfulness, and other practices that, the clinician could advise to their patients in the room without any specialized equipment or resources. Okay, and then we sort of, the last aspect, we talked around the guidelines for the platform of choice, because we there was a big emphasis on using, the internet or internet-based services as a model of delivering these resources because of access and all the challenges we already have, so leveraging the internet and access to then get the information out there. I think this is just kind of reiterating around that, when we give the information, we're gonna have levels thereof. So to start at a basic level, to make sure that we're all on the same page about what we're talking about, especially for maybe the less common conditions that maybe not everyone may be as aware of. And then to building up to more complex input, because we also realize that there may be different level of expertise and clinicians who may be accessing this input. So something general, and then so that can also cater for psychiatrists and other people who are already sort of fully immersed in that field, up to the level of experts. And the awareness of language came up. That again, if we're saying broadly across the African continent, we know that English is not the most spoken language across many countries, and so how do we translate the content to make sure that it reaches a wider audience as possible? And then it came up that EM Guidance app actually has the option of translating. So we thought, if we do collaborate with them, that could be then one way that there is translation underneath the video or whatever sort of mode of delivery we've chosen. And then the third aspect is around the mode of delivery. So again, being innovative around how we get the content across. People are not going to read long text. So we want to make it quite visual, podcast, interactive, storytelling, even doodling came up. And we talked about Dr. Najib. I don't know how many of you have watched this video. So we're like, Dr. Najib's strategy of having his little whiteboard there. He's making sketches as he's talking through the content, and how many of us as medical students have benefited from those videos, and we thought there could be a similar strategy for mental health related topics. And even on the podcast, we thought it would be so interesting to have, collaborations or interactions between specialists. We thought like we have a child psychiatrist sitting with a neuropsychiatrist and we're talking about the adolescent brain, and it's a conversation, and hopefully then people can get sort of insights from that. And then what is the best way to reach the audience? So that was kind of the general theme around that. And then we talked about the options again. I think I touched on that before. We then thought that we should have create a database, right? Because we don't want to reinvent the wheel. So what is already in existence? What are the respective organizations already put out? And if we could have a way of making that information available on these platforms, and then click a link, you can link out to ACAPAP or whatever organization that already has good content in that space, but maybe people don't know how to access that. And then the issue of peer reviewing of locally available resources, because we thought, okay, it's all well and good to say you need a CBT for the intervention, but it's like, okay, you don't have psychologists who's going to deliver CBT, but there is an NGO within this town that is doing good work here, and it will be the local clinicians so that's where the local vetting or peer review, that it may not be known to the broader country or continent, but that there's this little NGO that's doing great work, because there was obviously the issue around, fly-by-night NGOs or other organizations who are saying they're doing great work in the mental health space, and they say that's where peer review is going to help. That if someone in Uganda knows that this organization is doing great thing within this, village, then we would put that resource up, and that is the form of peer review we're talking about. And then the importance of co-creation of topics, that we don't just bring sort of our agenda and say this is what we think clinicians in Africa should know about, but to have an interactive sort of flexible approach to say maybe we have our first platform or podcast and say, then please give us feedback on what other topics you think are sort of the most pressing or the ones that you're struggling with the most within your area, because what we think is a need may not be a need. And the final sort of discussion point was we thought that there should be champions for each country and region. Because again, as I said, the work group was quite South Africa heavy, and we were like, we don't want it to just become a South Africa project. So we want to make sure that as many of the African countries are represented, and that if there was sort of a go-to person for each region, and we decided to call them champions for the region, who will then be able to tell us what do you have, because then if we know that there is a country with one psychiatrist, we may know again, in terms of equity, let's then maybe try and channel the content to benefit that country with one psychiatrist versus what do the psychiatrists in South Africa or clinicians in South Africa, sort of identify as a need where they are more resourced. So we thought if we have champions, then we'll know which country is most in need, and then we can see which sort of the levels of resource and needs that they have. And then so that was Anusha's last slide. So the next meeting will include all the interested members from this session. Thank you.
Thank you so much. Are there any questions for the speaker or the group?
Yes.
Thanks. Thanks for the presentation. Well, this cuts across research training and education in clinical care, but in the presentation, there seems to have been a way of excluding some forms of traditional healers who maybe, let's say, for example, we have many examples about the lack of psychiatric services in other African countries and also in South Africa. Whereas maybe we find that there's a shaman, there's in Uganda, there's somebody that is delivering services there. So how do we include them as part of the clinical care delivery? And also the inclusion of family members and communities in terms of healthcare services and so forth. Thanks.
So on your first point, yes, you're right. We had that discussion around, when we talk about the peer review, we were saying that the clinicians in that area will hopefully, know who are the legit healers in their space and who are, the good church establishments that are, really offering support to the locals as opposed to possibly doing harm. Because we didn't want to just have, to say anyone can just, put their link and, so it's about, there must be some sort of way of trying to protect people so that when we're referring them to say you can go to this traditional healer, someone has actually maybe had engagements or interactions with them to say, no, actually they're above board, and we know that, they're not going to do, actively try and harm participants. And then, sorry, your next question, you just remind me again, I didn't write it down. The second part of your question?
It was civil society community members.
Or involvement. So I think because we our more focuses around sort of clinician care delivery and how do we capacitate the local clinicians. So our focus is more around how do they do the assessment, and hopefully then they would engage with the locals and with the families and have that more patient-centered and family-oriented approach, because we obviously can't be able to get to everyone within the region, but it's about at least if the clinician is feeling more capacitated to say, okay, this is sort of the basic tenets of CBT, for insomnia, then they can hopefully get the family in, get the patient in, and get them on board to actually deliver that mode of care.
Hello, I'm Mrs. Swati. You spoke about you would find what is normal to then do the and what is not, right? And my question there is, who would be the decide what's normal and how would we then do that? You've spoken about the social and the cultural as well. And in South Africa, as you know, what's normal,
Yes.
it varies. So how would we do that without harming and excluding anybody?
I think that's a very important question, and I think, when you talk about, conscious leadership, we also need to think, even with whatever platform or mode of delivery we're trying to put across, we need to be conscious and aware of the message we're trying to get across. So, we could use the standard takes of sort of a journey like, the DSM and what everyone else kind of has declared as what is normal, but I think it's going to be an ongoing process and engagement around that, because as you say, normal, who gets to decide. And I think that's why we want to have a more interactive space to then actually get feedback from the users to say, actually I don't agree with, your definition of a, sleep disorder or, what normal sleep is. In our context, 4 hours is normal. Or, so we're hoping to have more, engagement so that we don't just come and say, this is what the international literature says. We're going to say, okay, but in Zambia, this is our experience, and then we incorporate in that so that we actually, we learn and co-create as we go along. I don't know if Nisha has some additional input.
Yeah, so I think what we were also focusing on from the clinical work group was to say how, like Nisha said, it's about capacitating the providers rather than sort of broad awareness for the general public is another later step. And part of that we were discussing was not so much around who decides what's normal or not, but actually clinicians, how do we capacitate them? If you don't know what is normal development, for example, then you could easily be treating a 3-year-old for ADHD if you didn't realize that actually part of normal tantrums is what happens at 3 years old. So when we say, rather than coming out and giving, 5 criteria for how to diagnose a disorder, let's start off from basics. What can you expect at this milestone? What is normal in that age group? And how do we then progress when you're looking for impairment? And how do you manage that impairment matched by the resources in your setting? So that was kind of the thinking around that clinical approach. Because what also came out of the group is just the idea that anybody can go and pick up a book and read the criteria. But what that actually means in your setting can be very different. So I suppose that's the normal that we're thinking about, rather than pathologizing anything or anyone.
Thank you, Lisha. I think it's exciting work that you have done within your group. And although some people were not in the working group setting, some, we have actually signed up for that working group. So I think it's really exciting work that you're doing. I think also it can become a powerful source of knowledge on what is actually going on at grassroots level within the African continent. The whole concept of action research and sort of bringing down or narrowing that lead time from when research is generated to when it translates to what's done. I think this can become an incredibly powerful tool to narrow that lead time and actually remove that kind of snobbishness and noses are high up in the air kind of thing around research and actually translating it to what is happening, what do people need, what do they have access for, how can we bring those two together. So yeah, I think this was just really to pass a comment to say it's really great work that your task team has done. Thank you.
Thank you so much. And we are glad that there are more members who are really joining. The more the merrier. Thank you, everyone.
And now we move on to advocacy and policy.
All right, good morning, everyone. Kanye and I will co-present as well as our fantastic participants. You just want to raise your hand briefly to show off that you were in the best working group. Good, thank you. All right, time to move on.